actually the clinical anatomy director for all things medical school here. So basically, I teach the first year medical students. I think some of you as postbacks are basically taking this program in a prepare for medical school, correct? Is that the goal, or do you guys, are there anybody here today different? What's that? You're taking it for fun? Oh, look, I totally respect that. A lot of people do that. So Chris asked me, he's out today, so Chris asked me to come in today and talk to you guys about two various regions of anatomy. And as I understand it, this is not necessarily a physiology course as much as it is a straightforward anatomy course, right? So what we're going to do is we're going to be reviewing two things with some goals in mind. So when you guys study, at least from stuff that I give you, my recommendation is you kind of focus on the learning objectives that I'm going to give you. All right, some may seem a little generic. Now, do you guys have a textbook or some sort of text that you use? All of you must have an Atlas, right? Interesting. There you go. All right. Well, so you have the internet, correct?
Yes.
All right. So that helps me understand kind of the speed at which I go, and I have a tendency to go, or have had a tendency to go very quickly, and I'll try not to do that today. My hope is that this could be more of a conversation. Now, he normally goes for about an hour. You want me to go the whole hour and a half? Because I can talk for an hour and a half. So what we'll do is we'll start off initially just discussing kind of the major bones of the skull. All right? And prominent sutures and prominent foramen. Okay? Or foramen, the term that you should already know as a hole, all right, through a bony process. Now, you guys are in head and neck right now. And my recommendation is when you're studying this material, so here's a recommendation. Are you recording? Good. Here's one recommendation. Associate every bony hole in the skull with a particular structure. You might have an artery. You might have a vein passing through it. You might have a nerve passing through it. Okay? We're also going to describe kind of the arterial supply and venous return to the cranial cavity. Okay? And specifically, actually, the blood supply to the brain. Okay? You're going to have to understand how we get blood to the brain. And I'm going to show you that on diagrams today. We're going to talk about the orbit. Some of this is going to be a little bit arduous because you're going to look into the orbit, I think, on Thursday, and you're going to all say the same thing. What the hell am I looking at? Right? Why am I looking at this? This is crazy. Function and location of the meningeal coverings of the brain. And then finally, one of the things that we're going to do is we're going to identify the general functions of all the cranial nerves. Yes, ma'am?
Will you also use lab?
What?
Will you also be in lab?
Will I be an instructor in lab? Probably not. Chris will be back by Thursday. Okay? And I think at the end, he gave me a list of structures that he wants you guys to focus on, and he does that at the end of every one of his PowerPoints. Okay? So I am counting on you, all right, as a group right now, to either stop me or slow me down if I am going too fast. I will not be upset. I will not be angry. And I want to make sure you acquire the information at hand. Now, it seems to me that in the laboratory, from what I've noticed, is that you guys are getting a smaller chunk of material than you're getting in lecture. Is that fair to say?
Yeah.
Okay. All right. So philosophically, I told Chris I was absolutely opposed to this. And he said, because I'm running it, and it's fun. Even though he works with it, it's fun. But one of the things, my recommendations, though, is that when you're memorizing this material, it makes it so much easier if you relate things to each other. As I said before, holes in the skull, whether it's a vessel, whether it's a nerve, that sort of thing, or a particular nerve, a particular muscle, a particular movement. Does that make sense? It just makes it easier to organize all that information. So that's what we're going to do a little bit today. Shouldn't be too tough. All right. So let's talk about the calvary of the skull cavity. Any of you have children?
Yeah.
What's that? Not yet? Okay. Well, I don't know. I know a lot of young people with children. All right. A couple of things that I'm going to point out. This is known as the skull cavity. It's also known as the calvary. And here's the problem. The rate limiting step of our heads, or rate limiting step of our brain size is basically limited by the birthing canal of the female member of our species, right? You can only pass a certain size through that canal. Really, have you guys done your heads yet? Have you done basically the ACO spine and things of that nature? That is basically the rate limiting step. I have to pass a head through the pelvic out. Okay? If you can't get it out, then you probably talk about the things like the fact that moms before this day and age didn't survive. Childbirth was like a big deal. It was a problematic event for women. Not so much anymore, cesarean sections, but one of the things, or one of the features of the calvarium is the fact that we do not have a completed skull, all right, in utero. In fact, what happens is we end up having various plates. And what you can see here is you can kind of see a frontal bone, you can see parietal bones, and here you can see an occipital bone. And what you'll note is at this point you have joints that will eventually become what we call fibrous joints. And fibrous joints are also known as immovable joints. These are bones that will come together and they will be filled with fibrocartilage, all right? They will eventually ossify to form our nice round skull, okay? But at birth, it's not that way, okay? How many of you have held a baby? You haven't had any babies, but all right, maybe you held a little baby, okay? Did you notice that soft spot that was at the top of their head? That was called the anterior fontanelle. And that's a region right about here, all right? Where you have not formally sutured the bones of the skull together. So as we pass through the birthing canal, all right, one of the things that happens is that frontal bone that you have right here will actually press inward. Your parietal bones will flip one on top of the other. All right? Yeah, that's a funny look. All right? But what's going to happen is these parietal bones are going to shift and they're going to flip out on top of each other in order to allow the head of the fetus to pass through the birth canal. Okay? It's a pretty restrictive area. And then when they come back out, all right, things normally will come back in shape. Now, I didn't include a picture of my son here, but I've got a fantastic picture that I took when he was born. But children will look like they have cone heads, yes?
How long does it take for the shift to go back?
It's a couple days. Have you ever seen, it's not uncommon for small children to wear these helmets.
Yeah, I have a friend who had a kid that wore it.
In part because what happened is that the shift was so disrupted that they were concerned that the skull, all right, would actually be deformed in a way. Now, physiologically, it's not going to be a problem for the individual. It's just you would have a weird shaped head. That's the only reason why they do it. Okay, because nobody wants a weird shaped head. All right, so they wear this little skull cap sort of thing. But over time, all these bones will shift back in place. Immediately after birth, everything should line up correctly. But you'll notice that, in particular, back here, in what we call the posterior fontanelle, right, this region right here, all right, what's going to happen is if you look at the child's head, you'll notice it has sort of an oblong sort of shape to this, particularly right after birth. Now, I noticed in my children it was a couple weeks before it went away. But once it does, they have a nice round head and they look normal. All right? So here's what happens, though. Over time, one of the things that happens is that you'll end up forming a fibrous joint between these three bones, okay? And what we do is we call this region right here bregma, and we call this region down here lambda, maybe because it looks like a lambda, all right? And why is this important to you? Well, at some point in your lives, if you become neurosurgeons, perhaps, or maybe neurologists, whatever, you can actually use these landmarks right about here in order to figure out where you are in a brain, okay? Because those landmarks are usually pretty stationary, or it's a way to basically target structures in the central nervous system, i.e. cerebrum, thalamus, various regions that you find in the brain in order to do things clinically, okay? And so they've been given those names. You're going to notice that there's a couple holes here, all right? We call these parietal foramen, or just foramen for what we call emissary veins, because there's weak communications that go down to the neuropharynges. I'll show you those in a few minutes. But for the most part, that is the calvarium, also known as the skull cap. All right? You should be familiar, okay, with these regions here. Be familiar with bregma, be familiar with lambda know that bregma is the anterior fontanelle, and bregma is going to be posterior fontanelle. Okay? All right. So I suspect, I don't know for sure, but I absolutely suspect that you will spend a fair amount of time looking at a skull in lab. You guys spend a fair amount of time with osteology? Some, a little bit. Well, if you're going to go to medical school, you might as well start right now. Okay? You might as well start looking at some of these features now. And my recommendation is the ones that you look at are going to be with the sole purpose, okay, of identifying stuff that's going to be clinically relevant. Okay? So what we're doing is we're looking at the lateral view of the skull, and you can begin to see some of the major bones. You can see the frontal bone. Here's that, what we call coronal suture, which is left over from those sutures that were wide open that allowed the frontal bone to press as it passed through the birth canal. You've got this large parietal bone located here. You've got an occipital bone, and then you've got a temporal bone. And there's actually two parts to the temporal bone. There's a squamous part, which means more or less thin, and it's actually located in this region right here. And then you've got the petrous part, or what they're going to call the masculine part of the temporal bone, which is more like a rock of your skull. You'll notice that when you look at the skull on Thursday. It's going to contain things like your vestibular apparatus. It's going to contain things like your cochlea, the apparatus that you use for hearing. You've got your mandible, okay, located here. All right. You'll notice that there is actually going to be a condylar process that we'll talk about on Thursday that's associated with the temporomandibular joint, which is important for those of you. Anybody here get massive headaches? Horrible migraines, anybody? It's not uncommon for that joint itself, all right, to be inappropriately seated, that it can actually result in headaches for people that you might run into from a patient. So a lot of people that go and get orthodontics, things that pull your jaw out a little bit more, will actually compress structures, or let me rephrase that, will actually relieve the pressure on structures that are passing out up underneath this mastoid process right here. We've got a styloid process. It's just a sharp process, which is going to give rise to a number of structures, suprahyoid and infrahyoid, or suprahyoid muscles that we'll talk about when we talk about the triangles of the neck. We've got a maxilla, okay, we've got a zygomatic bone. And then we've got a series of nasal bones on the medial portion of what we call the orbit, all right, that help make up the orbit. Deep to the structure, right about here, you have what's called the sphenoid bone, which actually has a shape of a bird when you disarticulate the skull. It'll have a greater wing and it'll have a lesser wing. And what you're looking at on the lateral aspect of that bone right here is going to be the greater wing of the sphenoid bone. Now, I want you to know, there are places right here, this is one of these places that you should recognize, that these different bones come together. So for example, you have the sphenoid, the temporal, the parietal, and the frontal. They will all suture together at a relatively thin place along the lateral aspect of your skull. That is known as the pterium. Okay? You need to know that location because I suspect you'll have questions on it. All right? But the reason why, the real reason why you need to know that location is that there's an artery that passes up underneath it to help supply what's called the meninges inside your skull. A lateral blow to the head, right about here, can rupture that artery. If it ruptures that artery, it can lead to what we call an epidural hematoma. Yes, ma'am? Yes, ma'am. Pterium, you said it correct. Now you're going to note too, down here, they're calling this the occipital mastoid suture, and they don't actually have it labeled on here, but there's another suture site where the temporal bone, the parietal bone, and the occipital bone will actually meet. Yes, sir?
What's the artery? What's the artery?
It's called the middle meningeal artery. Yeah, you'll see it when we look at the base of the skull. I'll show you some holes in the skull to help you remember it. But the middle meningeal artery will actually be derived from a portion of, you guys haven't done that yet. I think I have to teach you that too, because we're supposed to be like that. Right? But there's an artery known as the external carotid artery that will actually branch into things called, and I'm just giving you a preview of the future. It's going to branch into what we call the superficial temporal that you can actually see on your face, and a maxillary artery. And from the maxillary artery, right, which is a branch of that external carotid, you're going to have an artery that will travel up into the cranium responsible for supplying the meningeal coverings of the brain. And it'll pass up along the inside of the skull. You should see that on Thursday. It'll actually, it's so big, well, relatively speaking, it makes a groove inside the skull that you can see, where it'll actually split into an anterior and a posterior division. And it'll travel right behind this region right here. And so you've probably heard horrible incidents where boxers have died, you know, or like these UFC guys have died, because of the blunt force trauma blow to the lateral aspect of the head. You're actually hitting a region of your head that has the thinnest amount of bone. That thinnest amount of bone will actually cause a crack in the bone, sever that artery. And that bleed will actually push away the layers of the dura from the bone itself and compress the head. And the more you bleed inside your head, the greater the pressure. And one of the things that you'll see, I hope this picture's nice. No, it's not. One of the pictures, and I'll get back to it, one of the things that you'll appreciate at the base of the skull is this large hole right here. Okay? For those of you that are recording, I skipped a slide, but I will go back. All right? This large hole right here is known as the foramen magnum. So that bleeding inside the cranial cavity puts pressure on the brain, and this large hole will cause the brain to herniate out of the skull. Does that make sense? Okay. Other aspects of the lateral view of the skull. Things that you should also appreciate is that one of the things that you'll see here is the external auditory meatus. Meatus is just another term for a large hole. That is more or less our ear canal. Okay? It's the bony entranceway, all right, that is going to eventually lead to our inner ear. And our inner ear is going to contain the lateral bone network of structures that allow us to A, balance, all right, and B, hear things. Ruby? We on the same page? Any questions? Okay, so this is your orbit. Okay? This is your orbit. How many of you were cheerleaders? Excellent. What was your device that you used in order to get the crowd going?
Flash.
What? You guys didn't, like the cheerleaders at our school had megaphones. Remember those megaphones?
We didn't use my
That's more like alcohol.
I'm old. Right? I am an old person, right? But when you're thinking about the orbit, right, and you're thinking about the bony structures of the orbit, you need to think about the megaphones that the ancients, i.e. me, used. All right? When we were cheering for our various teams. All right? And the orbits themselves are these megaphones that project outwards in two directions, sort of a lateral direction in the skull. All right? And the apex of the orbit itself will meet back at the internal aspect of the skull. Okay? And what you need to spend some time thinking about, hint, right, are the bones that make up the orbit. Okay? So laterally, all right, the bone is going, the orbit's going to be made up of the zygomatic bone as well as portions of the frontal bone. As you work back towards the apex of that megaphone, okay, you're going to run into what we call the sphenoid bone located here. And you can see that large, or what we call the greater wing. I would encourage you to ask Chris on Thursday. We have what's called a disarticulated skull that has wires in it that allows you to see all the different parts, so you get a real appreciation of what that sphenoid bone looks like. It does look like looks like a bat or a bird. It's got this giant wing and it's got this much lesser wing. And that's how the ancients more or less describe it. Now medially, right, you've got some crazy things going on here. So like, for example, you have the portion of your maxilla right here that's actually around the distal edge of the orbit itself. You have a lacrimal bone located here. And then you've got this ethmoid bone and a small contribution of the palatine bone that you can barely see in the background. Okay? Within the greater wing of the sphenoid is where you're going to find the superior orbital fissure, which is a large crevice that allows a number of cranial nerves to pass from the internal aspect of the cranial cavity to the orbit itself. You also have what we call here, let me get my little pointer here. There we go. All right. You've also got this little hole here that we're going to call the optic canal. And the only thing that's going to pass through the optic canal is the second cranial nerve, known as the optic nerve. And that optic nerve is simply a collection of axons. Have you taken neuro yet? Good, with Dr. Haynes and a number of those. So then you know this optic nerve is simply just a collection of axons that are coming from the retina that are going to project back eventually to thalamus and then from thalamus to the occipital cortex. Groovy? Excellent. All right. So the eye, all right, would actually sit inside the orbit. A number of muscles would actually attach to it, and all these muscles would find their way back to an annular ring that you would find, which is kind of like this fibrous ring that actually sits in the apex of that cone that I described, associated with the orbit. Okay. So you will actually have the opportunity to look inside the skull, either a bony specimen or in some of the specimens that we have available for you guys to look at downstairs in the laboratory. The first thing that I want you to appreciate is that you've taken off the calvaria and you look inside the cranial cavity, all right? You have three major cranial fossa. You've got an anterior cranial fossa, a middle cranial fossa, and then a posterior cranial fossa. You kind of see those here, okay? You should be familiar, okay? You should be familiar with major landmarks located within each one. So let's take them independently, okay? The first thing that you're going to see in the anterior cranial fossa is you're going to note the vast majority of that particular structure is made up by the front bone, okay? That's called the pig right here, okay? And in the middle aspect of that middle bone is you're going to find what we call the ethmoid bone. Remember how I mentioned the ethmoid a little bit associated with the orbit? You saw it on that medial aspect of the orbit? So you get this ethmoid bone that sits in the middle, all right, of that anterior cranial fossa. It has a feature that you should be familiar with, okay? Highlight this. That feature right here is known as the crista gata, okay? It is a protuberance that juts from inferior to superior off that portion of the ethmoid bone. It is important because it is a landmark or attachment, okay, for the dura. In fact, something known as the falx cerebri, which if you've had neuro before, you should recall, separates the two hemispheres. Are we cooking with gas? You guys remember some of this? On either side of that ethmoid bone, you're going to see holes. Those holes are what's known as the cribriform plate. Has anybody played cribbage? Yeah. Is it like a... No, not the Harry Potter thing. No. I don't even know what that game's about. I just know there's a flying gold thing and some dude with superpowers is flying around on the room. No, there is a cribriform plate, like cribbage, a cribbage board. Remember you kind of move things on a cribbage board? How about this? Has anybody gone to, what is that restaurant that's on the side of the roads all the time?
Cracker Barrel.
Cracker Barrel. You know what I'm talking about? You know, they jump and see if you're how smart you are? That's what... All right, good. Right? Imagine, if you will, and you'll see this in the lab, imagine, if you will, looking at a region just like that, and we call that the cribriform plate. The reason why I was associated with cribbage is there's a game called cribbage, which you move things around. It's got a board that's very similar. Nobody plays it except for people that are old like me. I might as well play hearts. What do we do in nursing homes now? I don't know. All right? So, right? But the reason why it's important for you to recognize that is that that is going to be another site for what we call the olfactory nerve, cranial nerve number 1, that sends its projections from your nasal mucosa up through that cribriform plate to eventually synapse inside the olfactory bulb. Okay? So as we try to associate different things, you know, with stuff that we see in various landmarks, crista gata, you guys recall, was the attachment point for the derma, right? cribriform plate, now you know it's a bunch of holes in the ethmoid bone that's receiving all those axons that are coming up from the nasal mucosa. Okay? And for the most part, the posterior aspect of this anterior cranial fossa is then made up by a portion of what we call the sphenoid bone. Now, it is that region right here, all right, along what we call the lesser wing. See this lesser wing versus the greater wing out here? So there's a lesser wing here, and then there's a greater wing that's out here, normally observed from the other side. So to the ancients, it looked like a bird, so they describe them as wings, right? Is that now we move into what we call the middle cranial fossa. And you can see basically there are three bones that contribute to that region, all right? There's going to be the sphenoid bone, there's going to be the temporal bone, and then you can see portions of the parietal bone, all right? And what's kind of cool is now you're beginning to see a number of foramen on the base of the skull. As we move from medial to lateral on either side of the skull, you've got three prominent foramen. You've got the foramen lacerum, which from a clinical standpoint is normally not a hole. Nothing really passes through it. It's actually filled with cartilage, cartilaginous plug. You will see this hole when you're looking at the skull and wonder, well, what the heck is that hole? Turns out it's part of the carotid canal, as your internal carotid artery will work its way up through the skull. But there's a hole that develops during the process of actually making the skull. So nothing really passes through there. Some people argue you'll see a little emissary vein that'll communicate with the dura. But for the most part, nothing really passes through there. As we go more lateral, you're going to find a hole, all right, that we call the foramen ovale. Now you're going to review the cranial nerves. It's awesome that you had neurology, all right? But you've got a branch of one of the largest cranial nerves that'll actually pass through foramen ovale. Does anybody remember what that was? The trigeminal, which branch passes through foramen ovale? That's all right. I'm pushing you. You weren't prepared. It's okay. All right. I'm trying to push you. But do you remember the mandibular branch, or V3? Yes? No? All right. Makes kind of sense, right? Because you have this hole at the bottom of the skull, and you've got to get down to the mandible. So now you've got a portion of the trigeminal nerve that's actually going through foramen ovale, all right, and it's going to the mandible itself. Okay, mandibular branch of the trigeminal nerve. As we go even more lateral, we have what's called foramen spinosum. It is a small hole that is going to have what artery pass through it? We talked about it earlier. Somebody guess. It's okay to calm down. It's not okay to test. Nobody's going to guess. What is the covering of the brain? Oh, wait, what? Boom, nailed it. You get the gold star for the day. Put it in your permanent record. Nice work. Right, this is where that middle meningeal artery, all right, will course up through spinosum, and it'll actually split. They didn't really draw it in, but there's an anterior and posterior division. And one of those splits, look at this, actually look, they even write it here. Look, groove for the middle meningeal artery. Look where it goes. What the heck's this thing right here? The pterygium. All right? So it's in a suspect place, right? It's in a suspect place. It's like, wow, that's a pretty important landmark that you should probably know if you ever want to go to medical school and learn things like trauma to the head. Okay? All right? That artery will always course in that direction, so be aware of it. Okay? There is also a posterior division. They haven't drawn in yet, but you get the general idea. So here we have foramen spinosum. We have a middle meningeal artery. That middle meningeal artery is going to travel up through foramen spinosum. It'll eventually split, and one of the major branches will actually go right deep to the pterygium. All right, we saw it from the lateral side of the skull. Now we're thinking about the inside out. Okay, here, all right, we have this region right here is known as the hypophyseal fossa. All right, it's also known as what we call the sella turcica. Has anybody heard that term before? Have you? What does it mean? That's all right. So you heard the term before? It means Turkish saddle. Right? So to the ancients, right, they looked inside the skull when they had a skull available to them. And probably, back in the Roman time, this thing that looks like a large depression, right? And that large depression was actually a seat, all right, for a gland that is incredibly important to you, known as the pituitary gland, okay? And so to the ancients, what it looked like, this sella turcica, to them it looked like a Turkish saddle, because it had this big thing that sat in front and a big thing that went in the back. You know what I'm talking about? Have you guys seen this on the internet? It's on the internet. If you want to Google it, go ahead. Look up Turkish saddle. But you'll see a Turkish saddle, right? And they named the different parts of it, all right? And its other name, again, hypophyseal, all right? Because there's going to be you've got the two different portions of the pituitary gland, which don't worry about, right? But it sits right in this region, okay, as it's connected to the brain via the mandibular stop. And there is a tuberculosella, all right, the front part of that saddle, all right, or the anterior part of that saddle, and then posteriorly they have what's called the dorsal saddle. So it's kind of like a big U, all right? Imagine, if you will. I don't know, what do they ride horses in Turkey, right? I assume that's why they have Turkish saddles, but they have, I don't know if they're on camels or not. Regardless, it doesn't matter. It is the Turkish saddle, all right, located in the Mediterranean. So these are the main regions, all right, that you should be familiar with. Know the foramen, all right, the three foramen, and know the hypophyseal fossa and what it's related to. And so related back to the pituitary gland. Okay? Now posteriorly, all right, the posterior cranial fossa, one of the things that you have is you have the occipital bone, a little bit of temporal bone, all right, a little bit of parietal bone. This region down here, this suture region is known as the asterion. Not clinically terribly important for you. It's just another site of sutures with multiple bones come together, very similar to the pterion. Okay? But this large hole that you see here, that we talked about earlier, is known as the foramen magnum. Big hole. Don't write big hole in your test, Chris will mark it. All right? What you can then see just lateral to that, all right, is a canal. And that canal is known as the hypoglossal canal. Now, you will recall from your cranial nerve stuff, when you study neuro, you'll remember cranial nerve number 12. It is responsible for motor innervation to the tongue. Okay? That nerve will actually leave, all right, the medulla of the brainstem. It will project through this canal to target muscles of the tongue. Fair enough? If you look lateral to that, where the temporal bone and occipital bone more or less unite along the suture line, you're going to find a large hole on either side. And we're going to call that the jugular foramen. And its name was given to itself because a large vein will collect there. Okay? And that is where you're going to find your internal jugular vein, which is going to be primarily the largest pipe draining your cranial cavity. All right, any questions about major components inside the skull? No? Let us move on. Okay, you guys have all had your own. The only reason why I have this picture up here, all right, is to indicate that the major bones of the skull have their name, or the major regions of the brain have a name. I don't know which, but they're all related. Parietal region of cortex relates to the parietal region of parietal bone. Frontal cortex relates to the frontal bone. Temporal region relates to the temporal bone. Occipital region relates to the occipital portion of that bone. All right? In terms of function, we're not going to get into it, but I want you to appreciate the way you have this entire region shaped. The frontal lobe will live inside the anterior cranial fossa. Okay? The temporal lobes will live in the middle cranial fossa. The occipital lobe will live in the posterior cranial fossa. There is a cerebellum, known as the little brain. And this is the brainstem. You guys probably already know that. The only thing that we see here is the pons, and we see the medulla. We don't actually see the midbrain, which would actually be more rostral to that, because it's covered by this large feature of the cortex. you're studying. Okay? Okay. Dura. All right? The tough mother of the brain. There are three layers that are covering the brain. So you guys have some semblance of understanding. You should have seen it already. You saw it when you guys did the spinal, right? You guys remember the vertebral column and stuff? And you looked inside there, and you noticed there was that thick covering, right? What's interesting about the vertebral column is that the vertebral column is completely different from the dura that is located inside the cranial cavity. And here's why. The dura mater consists of two layers inside the cranial cavity. In the vertebral column, it only consists of one. Okay? And the reason why is that, well, not the reason why, it just is what it is. Sometimes you got to press the LP button, right? Is that there are two layers to the dura mater and the cranial cavity. There is what we call the periosteal portion, okay, which is the portion that's going to adhere to the inner aspect of the skull. And then there's what we call the meningeal portion. And that meningeal portion is more associated with the central nervous or the brain components itself. Okay? The rationale, okay, for having these different features, for having these two layers, is that they will split at various places. And the places where they split will ultimately form a series of sinuses. Not like the sinuses that you have in your head that you're dealing with probably right now because of all the pollen and spring and whatnot. But these are blood sinuses. These are like the veins of the cranial cavity. Okay? So I love this picture only because it shows you in cross-section of what those two layers look like. So here you have the periosteal layer. Right? Here you have the meningeal layer. That meningeal layer will split from the periosteal layer, and what you end up creating is what we call dural venous sinus. Does that make sense? The reason why you don't have it in your vertebral column is because the only layer that continues around the spinal cord as it goes down into the vertebral column is going to be that meningeal layer. The periosteal layer doesn't exist. So in the vertebral column, you actually have a true epidural space. So here you see a space. You don't actually see a true space between the bone, right, and the periosteal layer. But if I were to punch you in the pterion, and I were to fracture that portion of your bone and rupture an artery that lives in that space between the bone and the periosteal layer, you could develop what we would call an epidural hematoma. And this periosteal layer would eventually swell, blood would collect in this space, it would push on the brain, and eventually push it out to the foramen magnum, and you would die. And you would be on the fourth floor. Just kidding. It's not. Maybe not. I recommend everybody do it. I got sheets if you want. I've done it a long time. Alright? So that is the tough part. Alright? So that's one of the major differences between the dura that you see in the vertebral column and the dura that you actually see in the cranium. So the dura that you see in the cranium has two layers. It's got a periosteal layer, and then it's got a meningeal layer. And in various places that I'll show you in a moment, they will split, and they will form the venous system of the cranium. And so in this particular process, they're calling this the dural venous sinus. Maybe it's the superior sagittal sinus. Okay? Now below this meningeal layer, you're going to have a network, a reticular molar network of nerve that exists underneath that, and we call it the arachnoid. The ancients look like a spidery type web of structure. Okay? And it's between the arachnoid and what's lined in red here, known as the pia, is where you will find your CSF fluid, cerebral spinal fluid. This fluid is basically produced by ependymal cells from the lateral, third, and fourth ventricles. Right? And there's a constant flow of this fluid that's circulating through the ventricular system of the brain itself. At some point, all right, that fluid will actually get pushed into this venous system. And it does so, they don't have it, oh, they do, they show it right here. It does so through these specializations that poke through the meningeal layer of the dura You look at it. Ask Chris on Thursday to show you rack-on granulation. It's kind of cool. So it's like a pop-off valve. All right, you guys know what a pop-off valve. When pressure builds up inside the ventricular system, these rack-on granulations will push out into the venous system of the cranial cavity itself, and it'll push that CSF into the venous side of things, and it just gets pushed back into your blood. So that you don't ever accumulate too much pressure in the ventricular system, resulting in things like hydrocephalus, stuff where you got too much fluid built up inside the brain. Again, causing a similar problem, this time from the inside out rather than the outside in, of actually pushing your brain against bony structures. The reason why our skull is problematic is because it's made out of bone. And so when your brain starts to swell, it's actually smashing it up against bone. If you smash too much brain against bone, right, it gets squishy and you die. This is one of the reasons why head trauma, situations where you have an overproduction of cerebral spinal fluid, they'll actually drill holes in your head to relieve the pressure in order to protect the nervous structures that are contained within your skull. Yes?
So basically, if some hematoma happens due to one force injury, what they would do is they take off the portion of the skull and like drain it from that through the sinus.
Yeah. No, they don't drain it through your sinus. In the injury that you're talking about, right? There are two types of injuries that we talk about. One is you've got the ventricular system, which is not shown here, producing too much CSF, and these arachnoid granulations can't act like a pop-off valve to push the CSF into the venous system. All right. In blunt force trauma, one of the things that's happened is you've ruptured a vessel that exists between the perosteal layer and the bone. You bleed in that area, and it sort of peels back the periosteal layer, the dura, and pushes on the brain itself. What they would do is they would drill a hole in your skull and drain that fluid. Right? They wouldn't try to dump it into the dural sinus. That wouldn't work. Now, if you had a dural sinus rupture, which is not uncommon, so perhaps you have a rupture internally, and you split these two layers, and blood begins streaming out in between the two layers of the perosteal layer and the meningeal layer of the dura, what you have is what we call a subdural hematoma. And to be honest with you, the treatment's the same. You drill a hole and you try to drain the fluid before you hurt the brain. Make sense? You all cooking with gas? Good. It's good stuff. Okay, the reason why you have to understand that there are two major regions, right, associated with this dura, particularly the meningeal layers, is that there are specializations associated with those meningeal layers that allow us to compartmentalize, all right, the brain itself inside the skull. So one of the things that you'll be asked to identify is this structure right here, the false cerebrum. It is basically those two layers of meningeal dura coming together and creating a connective tissue barrier separating the right hemisphere from the left hemisphere. Does that make sense? There is what we call the tentorium cerebelli, right, which is a structure that separates the cerebellum, all right, which is living down here, all right, from the occipital lobe of the brain itself. You have a notch right here. This is actually pretty important because some of these pressures don't have to actually push the brain outside the foramen magnum. Some of them can actually just herniate part of the central nervous structure over a notch or pushing it through a notch, which can disrupt things and cause people to die. You'll notice that here you can see the cellulosic, right, or what we call the hypophyseal fossa. All right, here you can kind of see there would be a hole in it, and your pituitary gland would sit right in this specialization known as the cavernous sinus. Okay, and that's a region, right, of one of these dural specializations. Okay, where you have reflections both the periosteal layer and the meningeal layer that allows this endocrine/nervous structure to sample blood, all right, inside your skull in order to dump hormones in, evaluate what's going on, that sort of thing. All right? Yes, ma'am?
What was that called again?
This is called the cavernous sinus right here. Cavernous sinus is located right here. I don't know if I was supposed to tell you that, but it's pretty important. So you should learn it at some point. All right? you've got the tentorium, which is like a tent, and then down underneath the tentorium, okay, way down here, all right, we have what's called the falx cerebellum, which in a way sort of separates the cerebellum into two hemispheres. So the cerebellum is like a little brain.
So, current cerebellum is separated into which hemispheres?
Say again?
The current cerebellum is also separated into.
No, the tentorium cerebellum, this guy right here, imagine if you will, you've actually got your occipital cortex sitting on top of it. It is separated from the cerebellum that's located underneath it. Okay, it's still in the posterior cranial fossa by definition, but just below it you've got your cerebellum.
Okay.
The falx cerebri separates the right and left cerebrum. Okay, the two hemispheres of the cerebrum. And then the falx cerebellum, all right, down here actually separates a right and left hemisphere associated with the cerebellum. So tomorrow, I think Chris is going to have you look at the brains. We're going to look at the ventral surface, and you guys are going to review some of the cranial nerves. Okay? Now here's another thing that I want to point out. This is something that you should be familiar with. All right? I point out this is something that you should be familiar with to those recording. It's the slide with dural sinuses. There is a superior sagittal sinus located here. All right? It's going to drain back into what we call a confluence of sinuses. All right? You've got a straight sinus, and at the free edge of the falx cerebrum is where you're going to find the inferior sagittal sinus. Now again, these are specializations in the dura that are allowing the cranial cavity to be drained of deoxygenated blood. Okay? The inferior sagittal sinus will drain back into what we call the straight sinus. It will meet with the superior sagittal sinus down here to what we call the confluence of sinuses. All right? They will drain back via a transverse sinus, and eventually they will make a curved shape. And they will name it a sigmoid sinus. And that sigmoid sinus will eventually become the internal jugular vein. And it'll depart through the skull, through the jugular frame. You guys making those associations? Here, you were asking before what this structure is. Here is this cavernous sinus on either side. And you've got these smaller branches that might drain into it. But this large blood sort of cavity that is the result of reflections of the meningeal layers is going to be where your pituitary gland sits. It's going to sit in that bloody environment, and it's going to sample what's going on inside your blood so that it can release appropriate hormones from either the anterior or posterior aspect of the pituitary gland. This structure here, this sort of label right here, the label on the other one, like that. Here, this infundibulum is another term for the pituitary stalk that is coming from the hypothalamus. You guys remember some of this? Some of it coming back? For those of you that haven't had neuro, it's not coming back at all. I'm just learning for the first time. All right. There are communications, all right, that drain back to the sinuses. One of which is going to be this structure here, this ophthalmic vein, all right, which also has communications to veins inside your orbit. And in fact, they communicate with veins that are on your face. And it is a valveless system. And it used to be really problematic for individuals to get an abscess on their face and for that abscess to rupture because that bacteria could work its way back through those venous communications and eventually end up into the cavernous sinus. And when you end up in the cavernous sinus with an infection, you have a problem because that turns into a brain infection. And the brain infections usually, back in the day before antibiotics, would result in people going to the fourth floor. Okay? So it's something to be appreciative of when we talk about the face, is that many of these sinuses and these communications, all right, these venous communications, can actually have access back to those sinuses that are inside your those communications can lead to infectious problems, all right? Or the infection can actually lead back to your brain, which is going to be problematic. Okay? So again, okay. So let's talk a minute about blood supply to the brain. This is not necessarily blood supply to the cranial cavity. Okay? This is to the brain. So far, all you know about in terms of blood supply to the cranial cavity is one artery that you may see in class on Thursday, which we may talk about as a branch coming from the external carotid. There are 4 major arteries that will supply your brain, 2 of which are the internal carotids. The other 2 are the vertebral arteries, and they will all eventually anastomose. Have you heard that term before? So an anastomose simply just means connect. You can use it for nervous structures, you can use it for vessels. And in this case, all these arteries will eventually anastomose to supply various aspects of the brain. The 2 vertebral arteries will actually enter the cranial cavity through the foramen magnum, and they will unite. They will fuse together along the base of the brainstem, and they will become what we know as the basilar artery. That basilar artery will travel along the brainstem until it splits. It will split into a posterior cerebral artery. So you can kind of see it here. 2 major vertebral arteries traveling up. They unite to form a basilar artery. They will travel along the belly of the pons before they will split into the posterior cerebral arteries. These posterior cerebral arteries will supply occipital cortex. They will have small communicating branches, these posterior communicating branches, a right and a left, that will meet up and fuse with the internal carotid artery. And that internal carotid artery will give off 2 major branches. It'll give off an anterior cerebral artery. What's that? Am I really going too fast? I'll slow down. You can see it right here. Look. It'll give off an anterior cerebral artery that'll travel along the medial aspect, all right, of the hemispheres. And then it'll also give off a large lateral projection known as the middle cerebral artery, which will travel out and around to supply chunks of the temporal lobe as well as the lateral portions of the parietal lobe. The anterior cerebral will stay midline, okay? And it'll travel up and around the inside of the brain, okay, to eventually supply all structures along the midline. Now, why does this become important? Well, it becomes important later on because it turns out that people that stroke out in the anterior aspect, or a distal branch of the anterior cerebral artery, will often have deficits associated with their lower body. People that have strokes in the middle cerebral artery will have deficits with speech, and sometimes you'll see motor and sensory deficits associated with the face and upper portion of the body. And this is, as you recall, those of you that had neuro, I bet you talked about homunculus. So everybody remember the term homunculus? It is a neural representation of your entire body within the cortex. And as it has it, where the frontal lobe and the parietal lobe meet, there is a central gyrus. There is a pre and post central sulcus. I'm sorry, central gyrus. There is a pre and post central gyrus, and then there's a central sulcus, right? And the pre-central sulcus is all motor. The post-central sulcus is all sensory. And its representation going from the inside brain, wrapping around the lateral aspect, goes from your feet hanging inside that central fissure that separates the 2 hemispheres, and it's almost as if you're laying back on cortex with your face near the temporal lobe. And so, problems with the middle cerebral artery branching up and around are going to affect things like your face, your upper limbs, motor or sensory, depending on what little branch got affected, right? Problems associated with the anterior cerebral, right, are going to affect feet and lower limbs because your feet and lower limbs are hanging inside the central fissure. Posterior cerebral, visual. Okay. Now, this entire region communicates with each other, lastly through this last singular branch known as the anterior communicating artery. It's a small branch connecting the two anterior cerebral arteries. And in fact, one of the things that this does is it forms a circle. And most of you should be at least affiliated with this structure that ends up, this anastomosis of the vessels is known as the circle of Lewis. And in truth, most of us don't have a complete one. Like this is the cartoonist version of what it looks like in real life. I have a complete one. I'm very excited about it. I am on the back of my office. I showed everyone my complete circle of Lewis. But most people don't. Most people don't. Thanks for your proud. Okay, so these are just some learning issues that you might want to focus on as you're working. Okay, cranial nerves. I am so happy that all of you have neuro, because this is all par for the course, right? You guys have all had the cranial nerves. First off, here's the thing, and I've got to warn you, this is what you need to review with your cranial nerves. One, they have names and they have numbers. You must be bilingual. Okay? Two, they are sensory or they are motor or they're both. And as you're learning them, think about if I lose this particular cranial nerve, I will likely have this deficit. For example, if I lost the olfactory nerve, I would be at nothing. I would not be able to smell. I've done this in the anatomy lab before with my It is awful for about 30 days. You can't smell. Because you destroy the nasal mucosa. Now, do you recall where those axons, what bony structure those axons went through in order to get to the olfactory bulb? Vermiform plate, the axon. So you don't have to go back and study that. All right, optic. It's all associated with sight. The optic nerves are axons traveling back from a particular eye. They will cross the optic chiasm, and then the representation of a particular hemisphere will actually travel to one side, the right side, or the left side. Don't worry about the details of that. You probably have already learned it at some point. Now, the next couple of cranial nerves, all right, that I'm going to talk about are going to be the trochlear nerve, or the oculomotor nerve, the trochlear nerve, and the abducens nerve. Here is the bonus. They are entirely motor. And they're dedicated with the movement bias. Okay? The trigeminal, you'll know that it's primarily sensory to the face. With one exception, it carries motor fibers to muscles of mastication. So those of you that are chewing on your pens right now, chewing gum, that sort of thing, that's what it does. Okay? Facial is entirely motor. Okay? Muscles of facial expression. Now, if you spend a lot of time digging up details on this particular nerve, you might come back and say, well, that's not entirely true. Don't worry about it. For you, it's entirely motor. All right? Auditory. Okay? The vestibulocochlear nerve, it's sensory. It gives you a sense of organization and where your body is in space, and allows you to hear. The glossopharyngeal nerve, it is both sensory and motor. It does taste on the posterior one-third of your tongue. All right? And it also does some of the pharyngeal muscles that you're going to see inside the neck, specifically the stylopharyngeus. I don't know if that would know that. All right? Vagus, all right? This is a giant parasympathetic nerve that's dedicated for your entire body. When you guys studied the spinal cord, did you talk about a cranial sacral outflow of parasympathetic fibers? I saw a yes, and then I see a shrug. Probably. Well, here's the nice thing about the vagus nerve. The vagus nerve is a very complex nerve. It does have some motor functions, but for the most part, what you should appreciate is that it is primarily the parasympathetic input to everything in your body up until what we call the splenic flexure of your colon. It basically runs your GI tract. Okay? Spinal accessory nerve, we call it a cranial nerve, but it is a post nerve. It actually started from the the spinal cord, just like, hey guys, you know, you're part of the clan, it goes back up into the cranial cavity via the foramen magnum, and then it departs via the jugular foramen. We wanted so bad to be a cranial nerve. But it's not. The only thing it does is motor. It does trapezius, it does sternocleidomastoids, muscles that you will see or have seen. Okay? And then finally the hypoglossal. We know that it's the motor to the tongue. That's what it does. Alright? Most important muscle in my 4-year-old. Hypoglossal. It works. Great. Okay? Review those particular functions for those nerves. You should spend some time identifying on the base of the skull. And I'm going to point out optic. This is the olfactory bulb. Technically, it's not the first cranial nerve. Okay? The first cranial nerve are those fibers that are leaving your nasal mucosa, traveling up through the cribriform plate, and they are synapsing. This is like a third order synapse once we start processing olfactory information. For all intents and purposes, you'd say olfactory bulb is all right? Optic nerve located here. This guy that you see here, ocular motor, okay, and then this guy here, which is kind of cool, the trochlear nerve, it is going to be the only nerve that exits on the dorsal surface of the brainstem. I say again, it is the only one that exits on the dorsal surface of the brainstem. So if you see a nerve, right, that's coming from the dorsal surface of the brainstem, guess what? It's the trochlear nerve. This large nerve that you see down here, right? This large nerve that you see down here, that's your trigeminal nerve. You should be able to identify it. It's going to be on the palms. Okay? Here, you can kind of see the abducens nerve. Okay? Facial, vestibular cochlear, all right? Glossopharyngeal, right about here. And then you've got the spinal accessory, which is creeping up here. And then for number, that's vagus right here, by the way. So imagine facial, vestibular cochlear, glossopharyngeal, vagus, and then spinal accessory coming up. Note that they're all very lateral along the medulla. And the hypoglossal, it actually comes out just lateral to these structures here. You see the structure here? These are known as pyramids, if you guys remember. Those are large fiber tracts that are actually sending cortical spinal fibers down to the spinal cord in order for you to move about and create voluntary motion, things of that nature. All right? And then you have these bulges on either side. All right? This bulge right here. Do you guys know Dr. Hinkle? Dr. Hinkle loves the olive. I don't know why. He loves the olive. This is known as the olive right here. And in between, you've got what's called the pre-olivary sulcus. And the only cranial nerve that's going to exit the pre-olivary sulcus is going to be the hypoglossal nerve, which will go to tongue muscles and exit its very own canal, known as the hypoglossal canal. Good? And we'll look at some of that stuff as we move into that. And this is just another view. These are going to be, and here's the trick, right? Here's the trick. Learn the relationships of these nerves as they pass from the brainstem out through their respective foramina in the skull. It makes a perfect sense. So here you can kind of see the spinal accessory nerve. It's going to travel up. It's going to travel out through the jugular foramen. Cranial nerve number 9 and 10 also travel out through the jugular foramen. Okay? This nerve right here, the trigeminal nerve, it's going to branch out, but it's going to go out 3 different holes. There is rotundum, which is a hole that we didn't see in the middle cranial fossa that supplies this region of your face right here. Right? You see it in lab. All right? It's going to project out forward. There is the superior orbital fissure that we saw in the orbit. That's going to be the ophthalmic branch of the trigeminal nerve. And then you'll remember foramen ovale, right? Which was the mandibular branch of the trigeminal nerve going to the mandible. Okay, so it exits 3 different holes. Okay? The optic nerve, the only thing that's going to pass through the optic canal. It is the only thing that passes through the optic canal. We've got the olfactory bulb that's sitting on top of the cribriform plate, receiving inputs from the olfactory nerves. Now you know the facial, right, and the vestibular cochlear nerve, they will exit the skull via the internal auditory meatus. It's on the other side of the external auditory meatus that you saw from the lateral view. So your ear canal that you see here, the bony part, that's the external part. On the opposite side, inside that skull, you've got an internal auditory meatus, and your sensory vestibular cochlear nerve, right, and a motor nerve, facial nerve, are going to exit that hole that you're going to see when you look inside the cranial cavity. Yeah. So that leaves us with trochlear nerve, right, and the acoustics. And the nice thing about those is that they too, along with the ocular motor, they too will go to muscles inside the orbit, right, and they will innervate muscles inside the orbit, and they will do so through the superior orbital fissure. Yes? Good. All right. And there's, this is how I would recommend you kind of approach that key learning points that I was doing. So I think we're in the home stretch here today. All right? There are 7 muscles in the orbit. You should be able to identify all of them. Okay? The good news is that it's pretty straightforward how they're hooked up to the various cranial nerves. Out of those 7 muscles that are inside the orbit, only 6 of them operate the eye. Okay? So, the first one that you will see when you look inside the orbit is this guy, the levator palpebrae superioris. Palpebrae, meaning eyelid, means it connects the eyelid. When you activate it, okay, you're actually going to pull up your eye. For all intents and purposes, just think of it being innervated by the oculomotor nerve. Okay? That leaves us with 6 muscles that work on the eye. Okay? 2 are obliques because they attach to the orbit, all right, obliquely. And then you have 4 rectus muscles. Rectus meaning straight. Yes? Okay? Now, one of the things that you should spend your time thinking about is the function of these muscles and how they move the eye when you isolate them in a particular way. Now, for you guys to study eye movements, we don't have enough time to do that, all right? But one of the things that you will do if you go on to have a medical career is that you will use the eyes as a window into your patient's neurological status. And one of the things that you'll ask them to do is you'll ask them to move their pupil from one point, either laterally or medially, and then when you move it laterally or medially, you're going to then move it up and down, forming more or less an H. Okay? And the reason why you move the pupil laterally is as you move the pupil laterally, and you can kind of see this picture here. If I take this pupil and I move it laterally, that pupil is now going to be in line with the rectus muscles. And so if you elevate the pupil by pulling back on the globe itself, you're going to drive the pupil up. If you activate an inferior rectus muscle, you're going to drive the pupil down. But the first thing you have to do with that pupil is that you have to move it laterally. Does that make sense to everybody? So here you have a pupil. You've got our giant megaphones, right, that we have inside the orbit. They're actually pushed out in this direction, but the pupils are normally situated in this direction. They're actually, so we have stereoscopic vision, right? Everybody here can see depth perception. Because we have 2 sort of pictures of the world that our brain puts together. Okay? But those pupils are looking forward. And so in order for us to isolate a particular muscle, we have to move the pupil in such a way that only one muscle is really working on it in order to produce a particular movement. So in the case of the superior rectus, you want to drive that pupil laterally so that the pupil is now over here and it'll be in line with the superior rectus muscle so that when you pull on the top of the globe, you're going to drive the pupil up. If you activate the inferior rectus muscle, all right, one of the things that you're going to do is you're going to drive the pupil down. This is only when, all right, this is only when you move the pupil into the lateral position because the other muscles aren't contributing. The other thing it also tells you as you move the pupil to a lateral position is whether or not your lateral rectus muscle works. This muscle located here. So if you can't move your pupil out, you know that there's an issue with the lateral rectus muscle or the nerve that it gets a little more complicated when you move the pupil medially. And the reason why is because you have these muscles located here. You've got a superior oblique, and down here, you see this muscle right here that's kind of, they've kind of drawn it in so that it's up underneath the eyeball itself. It sort of attaches to the medial aspect of the eye, right? And one of the things that it does is that if you move this pupil in this direction, now the pupil's in line with that superior oblique. But the funky thing about the superior oblique is the way you think about that muscle is think about that muscle attaching from the front and rather than the back. So, do you guys have a marker? Is there a marker there? Do we have any markers right here? Nah, I was hoping I had one more. Do you have a dry erase board? Oh, you guys are awesome. Oh, you are awesome. Thank you. This is 2 gold stars for today. All right. So I want you to think of, how do I do this so that everybody can see? You know what? I will move. All right. If I have a ball, right, and I attach a muscle, and I'm going to put the pupil right here, right, and I attach a muscle like that, and I contract that muscle, what's going to happen to that pupil? Right, you're going to raise it. Ball, pupil, muscle attached, right? I pull on that muscle, I'm going to raise that pupil, right? Correct? Okay, now here's a question for you. I have a muscle that comes out here. It goes to a bony part that we're going to call the trochlea. Okay, it just means pulley, and it attaches here. Right? And if I contract that muscle, what does the pupil do? No. Anybody else? If I have something attached to this front of the ball and I pull it this direction, what's the pupil going to do? It's going to go down. Okay? And so now, did you guys see this? There's nobody behind you, so good. We got everybody right here. So now you can kind of understand it. The rectus muscles pull from the back of the eye, whereas the oblique muscles pull from the front of the eye. So the superior oblique, when you draw the pupil to the midline, okay? When you draw the pupil to the midline, is actually going to pull the pupil down. So the superior rectus, when the pupil is lateral, is going to draw the pupil up. But the superior oblique, when it's medial, is going to draw the pupil down. So vice versa, the inferior oblique, when you draw the pupil medially, is going to draw the pupil up. The inferior rectus, when you draw the pupil laterally, is going to draw the pupil down. Now, why is this important? We have 3 cranial nerves that basically do the muscles of your eye. The superior oblique is innervated by the trochlear nerve. Number 4. The lateral rectus is innervated by the adducens nerve, cranial nerve number 6. All the rest are done by the oculomotor nerve. So if I can't draw the pupil laterally, I must make the assumption of I have lost the lateral rectus muscle. If I draw the pupil medially, okay, and I cannot draw the pupil down after I draw it immediately, I have damaged the trochlear nerve. If the pupil in your patient is lateral and it's down, okay, it's in what we call a down and out position, that means the ocular motor nerve is failed. And all the rectus muscles, with the exception of the lateral rectus and the inferior oblique, they don't work. So the only muscles that work are the superior oblique and the lateral rectus, and they are now unopposed, which creates the pupil that is out because of the lateral rectus and down because of the superior oblique. Does that make sense? Sir?
Well, in that situation, why does the superior oblique pull the eye down?
It always pulls the eye down. It actually creates a torsional movement, but it's in combination with the lateral rectus and the fact that it's pulling from the front of the eye, that's always going to cause the pupil to go down. That was that whole pulling thing that I drew. All right? So imagine the superior oblique pulling from the front. Does that make sense? So these are the muscles that you, so these are basically the nerves that are actually going into the orbit. One of the things that I want you to appreciate is that there is a large presence of the trigeminal nerve. There's actually a nasociliary nerve, and by its name, it's going to be the ciliary region of your head. It's going to do like sensory innervation of your nasal regions. You've got a frontal nerve that's going to split. Eventually, it's going to reach to the front of your face. And this is all ophthalmic divisions of the trigeminal nerve that will travel through the orbit. And you also have a lacrimal nerve, right? Which is going to come up and eventually innervate the upper lateral quadrant of the orbit. It'll innervate the lacrimal gland, which is going to be responsible for tearing. Okay. Note that you've got a trochlear nerve traveling into this region. You've got your oculomotor nerve traveling into this region, and you've got your abducens nerve traveling in this region. The biggest ticket items that you need to appreciate is what are they hooked up to? Okay. Trigeminal in this region is just sensory. It's all sensory. Right? The motor nerves that are just motor are going to be the oculomotor, the abducens, and the trochlear. And there is a lacrimal nerve that is actually a branch of the trigeminal, but it's a nerve that goes with the gland that allows for tearing. This is just basically looking at the eye, all right? And Chris wanted you guys to understand how tears work. And so your lacrimal gland is actually located in the upper lateral quadrant of the orbit itself. Your tears be produced, and there's these little caniculi that'll actually present into the globe. You'll actually sweep tears across your eye. They'll be collected medially, all right? And there's what we call lacrimal caliculi that are located on the medial aspect. They will drain into what we call lacrimal sac, and then they'll eventually open up into the inferior meatus of your basal cavity. Okay? This is why when you're crying profusely, perhaps prior or post an anatomy exam, your nose will fill up with fluid. And that's because you get an overproduction of tears. The lacrimal gland is basically shunting all those tears that are actually spilling out over your eyelids and eventually into your nasal cavity. In terms of the blood supply to the orbit, Chris wanted you to understand that there is one major artery that goes into the orbit. It is the ophthalmic artery. That ophthalmic artery is a branch off the internal carotid artery. It will follow the optic nerve. It will split into divisions. There's actually a nasal artery. There's don't worry about the different branches. Just know that that ophthalmic artery is branching off of the internal carotid to supply the organ. There you go. These are some of the. This is one. If you memorize this, it'll make understanding what's going on in the orbit pretty easy. So SO4, right? Superior oblique, 4 trochlear nerve, LR6, 6 abducens, lateral rectus. All the rest are 3. You know that there's 7 muscles in the orbit, 6 of which drive the others. I did not hear what you just said.
Lateral rectus, 6.
Yes. SO4, LR6, all the rest 3. If you memorize that, it'll be easier to put those things together. So, a couple things before I let you go. Things to remember, right? Is 1, associate all the holes that you're going to learn with either a nerve or an artery. It makes it remembering their names easier. Okay? 2, remember with cranial nerves, you've already had them before, so this should be pretty simple, but be bilingual. Learn their name, learn their number, and then generally learn, is it motor, is it sensory, or is it both? Okay. And then when you think about functional, like the function of muscles in the orbit, what you want to think about is you want to think about, how do I test them? And the way you test them is you drive eyes, either medially or laterally. You move your pupil up or you move the pupil down. All right. You guys good? You had enough? It's not very responsible. Okay? That's all I got for you.